Hello and welcome to this edition of Your Health, Your Wealth. My guest today is Laura Crandon. And Laura is the founder and president of Touch for Life. Laura is a breast cancer survivor. And after going through her journey, she started this nonprofit with a mission to increase breast health awareness, particularly among what's called the BIPOC community. So when I say that, I'm talking about Black, Indigenous, and people of color and underserved communities. So she's a well-recognized and accomplished in the healthcare field. So the reason why this issue is so important is that with her organization, Laura is calling attention to the fact that disparities in breast cancer detection and treatment and survivorship that exist among Black and brown women in the United States. Black and brown women are dying at a 41% higher rate, and these statistics are just staggering. So we're going to dive into that. And another caveat, a very interesting part of her story, is that she has seen this journey on both sides, as Laura is a former healthcare executive at Care First, Blue Cross Blue Shield, and United Healthcare for over 15 years. So Laura, first and foremost, can you just tell us a little bit about your personal journey with breast cancer? What was your initial reaction when you were diagnosed, and how did you find out about this diagnosis?
Well, I just first like to say thank you for having me. My parents would just barbecue me if they were here if I didn't say thank you first for having me. And I always like to invite the ancestors to be present with us. For me, that C word, like anyone else, it was shock, it was anger, it was, how did this happen? I had what I thought was an all-clear mammogram just 5 months prior. It said dense breast, and I thought, cool. But what I didn't know then is that dense breasts mean that the radiologist can't see. It's like a weather forecast. There's something in the sky, but you just can't see it. But I didn't have any additional screening. Like about half the women who look like me don't get anything. No additional, no MRI, no ultrasound. I just happened to be doing a self-exam myself and found something that didn't seem right. It felt like a finger-length potato. And I thought, this is unusual. And got that checked out, had a biopsy, and it turned out, got a call and said it was cancer, and you just burst out crying. But really the feelings were shock and anger because it was missed. And that's not unusual.
Yeah, and from my understanding, and tell me a little bit more about the journey. Like, I understand that it may have spread and so forth. Tell me more about how that impacted your life directly as you were going through this process.
Yeah, so I was one of the fortunate ones who received what's called biomarker testing. It's this long word, but it really means that they figured out what type of breast cancer I had. I didn't know at the time that there were different types. I thought breast cancer was breast cancer, but that's not true. Mm-hmm. You really, really need to know what type you have. Some people know it as triple negative. Some people know triple positive. I've had triple positive, which means that they took the time to biopsy what was driving my particular type of cancer. And what was driving my type of cancer was quite aggressive.
Okay.
And all the markers were positive for me, which meant that they had to do chemo first. I did surgery and radiation and have really targeted drugs. That's what I was afforded. But a lot of women who look like me don't get that type of testing.
Wow.
That's why I'm on this show. It's because people don't know to ask, what type of breast cancer do I have? And don't get that type of treatment. So I got targeted treatment, had all those things, chemo, radiation, surgery. And then even with that, what I didn't know then at the time is that the recurrence rate for Black women is 39% higher than white women.
Wow.
And what happens is that the doctors quote a study that say that recurrence is unlikely But you know who that study was based on? Women in Sweden.
Okay. Okay.
Not us. We're not in the data. When we're not in the science, when the guidelines get written and these kind of standards get set, then they're set without us in mind at all. And so we're living with these guidelines that don't really apply to us because we were never contemplated. We were never thought of when these guidelines get set. And so I didn't know. I would have made maybe different choices if I had known that this standard was set without me in mind. But it recurred for me. I got this headache that I couldn't shake at my brother-in-law's 50th birthday party. They called me a lightweight. I thought it was a hangover. And I started hearing music that nobody heard.
Okay.
And voices, not like schizophrenia, but like it turns out that in my brain I had what's called a midline shift.
Oh wow!
Like the brain is symmetrical. It's the same on each side, except for my brain had swollen so much that part of my brain that controls the music and sound had moved over. Wow! Because the tumor was so big that the brain, as a protective measure, I'm talking to you. You're a doctor. Yeah. You're a neurosurgeon. But as a protective measure, it had swollen, and so and I had to have surgery right away. Wow! To take that tumor out, and once they had taken the tumor out, I because I'm a health plan executive, I was a health plan executive at that time. I knew to ask for second opinions. But so I was followed by 2 doctors, and one doctor I said, "What's next?" And he said, "Well, you're a woman of faith." And I said, "Yes." And he said, that was it. And so... Oh, wow. And it's like, sort of like, yeah, you're having a heart attack. Yes, you pray, but you also call 911.
Yeah, absolutely.
That sort of thing. The other doctor, fortunately, was cared enough to look up clinical trials and put me in a clinical trial. Very rare. For us, only 3 out of 100 people that look like me are even in a clinical trial. That's how I'm even talking to you today, which is why what's going on right now in the country is criminal, because I wouldn't even be alive. I was in an NIH clinical trial for brain metastasis, and that's how I'm alive. That person put me in the clinical trial, and I mean, it's not like you go to your local pharmacy for these drugs. Yeah. You have to go to NIH to get these drugs. And that was my journey, and so I had this treatment.
Yeah, and you mentioned you are a former healthcare executive, and do you think that experience on the other side, being in the healthcare executive, how did it shape or help you in your journey along the way?
Wow. I mean, well, I'd say even in spite of that, I experienced inequity, as I explained. I think 2 things that made me keenly aware. One, getting a second opinion, that all doctors are not the same. No offense. That I've done a lot of work on quality measures, that everybody's not good at everything. And so I knew to get second opinions. I knew to, look around. So that helped me with my decision. I'm grateful for that, because if I had only gone with that one doctor who had no answers, I literally wouldn't be talking to you today. And then also, I think it was important to understand I knew to know who was on my healthcare team. Like that you have a team and you have a right to have a team. Yep. You have a quarterback, and you have an offensive line, you have a defensive line, you have a coach. Yeah. It's a team, and you're part of the team. It's not just, you're not in the stands. Like, you're part of the team. And so they need to be communicating with you, and you're part of the decision making. And I knew that was possible. And then somebody who's not on Team Laura, I'm sorry, I know you're good at your job, it's just that you're not for me. Yeah. It's not you, you're just not for me, and it was okay to let you go. Wow. You're just not part of my team. And that helped me along my journey. And I'm not going to lie, I had access. I had the right to call the chief medical officer of a large company to bounce things off of. But you know what? Touch for Life, what we do is we make sure that anyone in our family, in our community who comes in contact with us has that same type of access. We make the experts available to our community. That's the commitment that we have, whether you're in Biloxi, Mississippi, or Boston, Massachusetts.
Wow, that's so awesome. And I don't know if most people really realize or appreciate the genetic aspect of what you mentioned earlier as far as breast cancer. And so give us some insights as far as your opinion, as far as the access to like genetic testing in breast cancer, because not all breast cancers are alike. And you have different variants, have different genetic markers. So yeah, tell me a little bit more about that.
I will, full disclosure, I am not a geneticist. I am not a pathologist. I'm not a doctor. I'm not a scientist. I have a computer science degree, but I hardly can work a remote control, as my kids remind me on a regular basis.
Yeah.
So I do want to make a distinction. There's genetics, and then there's biomarkers. And I know these are like super geeky terms. But think of it like this. Think of any plant, think of your favorite plant, a rose bush, right? And think of a bulb or a seed. You get a bulb or a seed, and that, let's say I like hydrangeas. I'm just partial to them.
Okay. Beautiful
that
plant.
That seed that you get, yeah, it's a beautiful plant. And think of it, that seed that you get, the hydrangea seed, you put that in the ground. Think of that as coming from your mom and your dad. That's your genetics. It's going to be a hydrangea no matter what. You put that in the ground, it's going to be a hydrangea. Now, whether the blooms are going to be blue or purple or pink depends on its surroundings and whether it gets enough sun, enough water, is it acidic, what's it growing next to, that sort of thing. That depends. So your genetics is something you inherit from your mom and your dad. Don't forget that you inherit risks for breast cancer. You can inherit that from your dad. If your dad had prostate cancer, it can put you at risk as a woman for breast cancer. And for me, because I had breast cancer, I could put my children, my sons, at risk for prostate cancer. And so you can inherit those things. They can't change. Like you inherit that. Now what can change is what you're exposed to. And so like I talked about, they cut that tumor out. So let's say you got that hydrangea. All the blooms are blue. And then there's one random one that's pink. And you're like, why is that? Think of that as like your tumor. You got to figure out, why is that pink? You got to cut that out, open it up, and see what's inside of it. What's making that one different than all the other ones? Think of that as like your biopsy. And what mutation's happening? Is it the sun? Is it dry? Is it acidic? Now you're talking about these other, what are called mutations. Okay. These other biomarkers. And you got to figure out what's that specific thing that's driving this particular bloom to be pink. And I'm only going to target that. I'm going to only target what's driving that. And I'm going to leave all those other blooms alone. That's what's called biomarkers or precision medicine, precision oncology. That's what I got. And that's what you want. That's the way of the world. But what's happening is we're not getting that kind of test. Like that's what's telling you what kind of breast cancer or prostate cancer or whatever cancer you have. That's what's telling you what you have. And you need to know that so that you get targeted medicine, not just a sledgehammer of something from 25 years ago that just goes in and wipes everything out, and it's not targeted. That's the way at least I think of it. I hope that makes sense.
Yeah, that was a very beautiful and eloquent way of putting it, and I never thought of it that way. But you're so true, and all of these different biomarkers and different types react differently and need different treatments. And the whole notion of precision medicine and precision healthcare is becoming so pertinent amongst cancer and other conditions now, as we move into this arena with so many different treatments and so forth. So it's important to get those type of tests, but as you mentioned, there are communities that aren't really getting those tests and getting that awareness at the same rate as others. And that's part of your work, is you're looking at health disparities and health equity in breast cancer detection. So in your research, what type of numbers or what are you seeing as far as those disparities?
Yeah, so I like to think of it like this. Imagine there are 10 of us playing musical chairs.
Okay.
And the music stops and 2 of us have seats. That's what it's like to be black and have cancer in this country.
Wow.
2 of us are getting to live on and hear the music and keep on playing. That's kind of how it is. It's just that stark. We're not getting the tests. We're not getting the treatment. We're not getting to take advantage of all these advances. I mean, every day you're seeing advances in cancer, advances in discovery, this, that, and the other. But that's only if you know what is in that pink bloom. That's only if you know what's driving. Mm-hmm. And the other thing is that I mentioned, earlier on we were talking about setting those standards, that study from Sweden. Well, also we're not in the data. Like, you can't find what's not there. So when folks, the scientists, are going to look for, hey, what are the mutations that are driving these cancers? When our blood and our tissue and our saliva is not in the bank, you can't withdraw. Like, what's not in the bank? So then there's no mutation to find. But we're part of a study. We're doing research around that, around the world, under the illustrious Dr. Melissa Davis out of Morehouse School of Medicine, under her leadership. Just so grateful to be under her leadership. But because we've got to participate in the research. So when they come and ask you, will you participate in a clinical trial? Will you donate your blood and your tissue and saliva? It's not just for you, it's for generations to come, because they won't have the data. They won't have our deposit to even know what's driving our cancers, to answer any of the questions. So I just want to make sure I make that plea as well. So I just donated to another study because I want to know. It might not solve it for me today, for me to live another 5, 10, 15 years. But gosh, 30 years from now, I want the next generation, I want them to figure this thing out, because there's something that triggered it for me, and I want to make sure the next generation doesn't have to deal with what I did. So I want to make sure that we are getting the genes, that our genes are counted, that they matter, that we're getting tested, that we're in the research, that we're in the standards, and that the doctors are ordering these tests for us. And even if you've been through your cancer journey already, you have this technology is changing all the time. It's sort of like an iPhone 6 versus like an iPhone 16. Like, it's changing all the time. You can go back and have it tested and see if you're eligible for something else. Or like, now, is there some therapy that's available for you now that wasn't 10, 15 years ago? They used to just test for 2 genes. Now it's like 27, 47, 80, these other things that become available. And you have the right to know, is something available that they should be screening for, or that now is available that puts you at a higher risk of recurrence, or that you could be treated for right now. You have the right to know.
That data is so important, and especially in healthcare, we're moving into this AI-driven healthcare and all this thing, and data is so important. And so getting more diverse involvement in trials, because like you mentioned, it may not be even for that particular research or that particular trial, but that data is housed, and it could be something that could lead to some breakthrough in the near future.
Yeah, because think about it. For AI, what AI is fed is what it's fed. So if it's fed all the images and all the images don't look like us, that's the baseline. Mm-hmm. Or if all the data doesn't look like our bodies and our cells mm-hmm. and our tissue, then it establishes that as, the sweetened baseline. And then everything else is compared to that. But, really, our Black genes matter. And that's why it's so important for us to participate and demand participation.
Yeah. No, I think you're absolutely right. We can't sit back after the fact when these treatments are put out and, we complain and say, well, we don't really know how it's going to affect people of color or other communities when we weren't a part of the research going into that. So I agree with you 100%, and I am a proponent for getting involved from a research standpoint and making sure that those numbers in a lot of these clinical trials, truly represent the population.
And that burden isn't just on us. I don't want to lay that squarely on our community. Uh-huh. That burden lies with the manufacturers of the drugs and devices. It lies with policymakers, and these are things that Touch for Life does. We hold clinicians, researchers, biopharmaceutical and device companies and testing companies accountable for being inclusive of us. I started Touch for Life because I just thought it was so unfair that I looked up and what I got, I was a unicorn. That just didn't seem right. It was wrong. And I couldn't stand by and just have it for me. It had to be for the whole community. So it is about accountability and holding them accountable. And just a short story is, I was taking one medication. We were at the dinner table, my youngest son and I, and he turns to me and says, "Mom, you're turning black." I'm like, "Yes, son, I've been black all my life." He's like, "No, you're turning black." And so like the insides of my hands, my tongue, my lips, and I thought I was going into like organ failure, panicking, right? And so I'm like, I don't know what's happening. And I had taken a new medication, and I look at I read the side effects, and it says may turn red. And so what that tells me is that no one with melanated skin was in their clinical trial, because it should have said something. I know this is a big, long word. It should have said hyperpigmentation, right? Because that means for someone with dark skin, you would turn black. That's what would happen to our skin. We would turn blacker, darker. And even like some of the risk factors, when you look on some of the large, well-known breast cancer organizations, even when you look at risk factors, they say, like the areola may turn red. Well, but that's not going to, like if it's already black or brown, that's not going to happen. Okay? It'll turn darker. Yeah. That's why like our brochures show darker. We show darkening. Not reddening, because it's already, that's not going to happen. Yeah. Things like that. But holding them accountable to make sure that we are represented, because then you are frankly a clinical trial of one when you take the medication. But everything goes through a clinical trial.
So you mentioned a little bit about what got you started, why you started Touch for Life. But yeah, tell me about Touch for Life. What are you doing, and where do you see the future? What are your future plans for the organization?
Yeah, so Touch for Life, I volunteer my time. So, I have brain mets, so it's so stage 4. But this is what I do. I've been called to do this, is to help people. And to solve this problem, the gap that you talked about at the beginning of the show, the gap is wide, it is deadly, and it is criminally unfair. And so there is not one solution. This is Touch for Life's perspective. There is not one solution. It is not just educate the community. It is not just advocacy. We take a multi-dimensional approach. We call it an ecosystem to solving this problem, because we didn't get here overnight, and it's systemic. Okay, so the way that we solve the problem is, yes, we do go out to the community. We go to conferences. We go where the people are. Lots of people. Conferences, sorority, fraternity, other organizations. Educate the people. Yes, here are the rights. Here's what no one's telling you. You should be mad, and you should be doing something. We train, so we have workshops, webinars, in person, etc. Second is we train people how to advocate. It's called Behave, because I was told to behave. I showed up for an advocacy day, and I started asking questions, and I was told, "It's okay, honey, just tell your story." And I was like, yeah, that's not going to happen again. And so we train people how to use their story and their voice to change policy at the state and local level. So we do that. Third thing we do is we go out to medical conferences. So researchers, clinicians, and the big conferences, AMA, NMA, National Medical Association, American Medical Association, the cancer conferences. They have all kinds of acronyms I'm not going to bore you with. At any rate, what we do is we also use data. That's what being a health plan executive also teaches you. But we survey them and we challenge them. I talked to about 4,000 clinicians a year and ask them about their ordering patterns when they write prescriptions for these tests and refer people to clinical trials. What do the people look like? And they're really brutally honest. They don't include us. And they tell us that they don't. And I challenge them to be better. The other thing that we do is we work with industry. I talked about that. To challenge them to be better with their inclusivity around their trials and their drugs and drug development, et cetera. So we sit on a lot of advisory councils. We also field a lot of focus groups to advise them on how to deploy their clinical trials and collect evidence. And then lastly, we do research. So we've got a few research studies that are in play. We did a Black Genes Matter study, the U.S., Caribbean, and Canada, and some global research that we're doing around attitudes. Because a lot of people say, Black people don't want to know their genetic risk, or Black people don't want to know their biomarkers, and that's not true. Our data show that we do want to know, it's just no one's telling us. And we will act. 100% of the people that come from our workshops learn a new fact. 86% of them walk away and say, I wanted to get tested. It's just that no one's offering it. And so we've got data. So we take this multifaceted approach. And what we see for Touch for Life is we want to be in every state in this country. We want to be on every mouth in this country and saying, Touch for Life taught me something new. Touch for Life helped save me, taught me how to do things differently, gave me a second chance, and made a difference.
It really sounds like you are out there in the community, and I'm glad to have this opportunity to talk with you and get this out there to viewers to hear more about this organization and how to get involved, because as you mentioned, this is how we can tackle these issues of health disparities, is by getting the word out in the community, letting people know about these differences, particularly in breast cancer, and getting the right testing so that we can push this forward. So how can people get involved with Touch for Life?
Yeah, we've also branched out to prostate cancer as well.
Okay.
Because of the genetic connection between prostate and breast. So we've got brothers in the mix too.
All right.
And, and it's not just one person who gets cancer. A whole family gets cancer.
Absolutely.
So it's breast and prostate for sure. So at Touch for Life, Inc. is our handle on social media. We'd love for people to join our community. And so there'll be some links that'll be going out, but it's basically you sign up and say you want to get more information, what kind of information you want. touchforlife.org is our website. But there's a form you can fill out. We can put you on our list. And join our family. It's really a family that we're very protective of. And we want to make sure you have the information. And if we're not in your community, if we're not at your conference, you should be contacting us. If we're not in your state, you should be contacting us.
Yeah, we gotta get this, like you said, all 50 states.
I'm not opposed to the Caribbean either.
Yeah, absolutely.
I like sun.
Yeah, it's take this international, absolutely. But no, I think I try to emphasize preventative care with this platform by knowing some of these risk factors, knowing a genetic disposition, looking at our family history. So I applaud you for what you're doing and support and getting this word out and helping people to understand that they have a place where they can go if they do have these questions about things like family history and genetic predisposition and so forth.
Oh, can I just say 2 words about family? Family history is so important. We have some tools on our site about family history collecting. We're just perishing because of lack of knowledge, honestly. We're not talking about, we know so-and-so died, or we say cancer runs in my family. What kind of cancer, And we're just not talking. And some of these cancers really do put us at risk. And it's okay if you don't know the answer or you don't really know or it brings up some ghosts. It's all right, But some information is better than none. And I will tell you a real important secret that will help you get it covered by your insurance. I hope you're listening.
Yeah, I'm all ears on this.
There is a difference between the answer, I don't know, and it's not knowable. I don't know says, it's possible to know, but I just don't know. It's not knowable says maybe I was adopted or the person passed away or what have you. And it's not knowable is equivalent of, yes, it's a risk factor. And that puts me in a high-risk category, which means I'm more likely to get it covered by my insurance.
Interesting.
That's a pro tip.
That's it. Hey, that's powerful.
And these are the things we teach, right? We're here to help you. We are here to help you and to make sure that it's really important, the family health history. So, we got holidays, barbecues coming up. Oh, and Touch for Life, we like to have fun. Some of our programs, like we have Party with a Purpose, by the way. Wear your black jeans to learn about your black jeans. Wear your black boots to learn about your black roots. We have fun. Like we have parties, and then in the middle of the party is a little fireside chat where we drop a little knowledge, and then we go back to partying. Because nobody wants to come to this cancer thingy. Nobody wants to do that, but we like to party. So these are the types of programs that we bring to hopefully your state, and then share it with others. That's what we want to do.
Well, Laura, thank you again. This has been great. I certainly have learned a lot, and I know that the listeners and the audience have something they can take away as well. Give us the website again.
We are touch, the number 4, LIFE, life.org, O-R-G, because we are a nonprofit, 501c3, touch4life.org.
Thank you again for joining me, and thank you all for tuning in for this edition of Your Health, Your Wealth. Please subscribe and like, and if you took something away from this, please share with your network, with your community, with your family, and tune in for future episodes.